Zoom will be up in a minute.
Okay, sorry guys for running a little bit late. The opening thing took a few minutes late and we're having a few difficulties getting Dr. Vokes in. As soon as she comes in, then we'll go ahead and get the event started.
There
Oh,
she
we
is.
are.
Okay,
Go ahead, just.
Yeah,
there she is. Good morning, Dr. Vokes.
you go ahead and share your presentation and share your screen. I'll let Michelle walk you through it.
Okay, give us a few seconds for Dr. Vokes to be able to share her screen and whatever she needs to do. I guess I will introduce, this is Dr. Vokes from the University of Chicago, and she will be talking to us today about the quality of life with hypoparathyroidism.
Are you going to put up the slides or allow me to share the screen?
You can share the screen. Just click the button on the bottom of the thing, Dr. Vokes.
Okay, let me just, I'm sorry you asked for the slides, so I thought you would.
Oh, if you want us to, let me
No,
see.
that's fine. That's fine. Let me just
Okay.
put it into correct view. And how many people do you have?
58 right now online.
Okay. Would it be possible to have some audience answer questions?
Yes, yeah.
Okay. So it's a pleasure to be here with all the technical difficulties. It's almost like having hypopara in the system. And I will be talking about something that I think is extremely important in managing hypoparathyroidism. And that is the quality of life, which is ultimately what you experience day to day. And it could be very different from what the physicians and the medical science tends to pay attention to, although that's also changing. So, organizers, could we put up a question, please, asking the question, do patients with hypoparathyroidism have impaired or diminished quality of life? Yes or no would be the answers.
Yes. So there is a lot of people saying yes to your question, Dr. Vokes.
Okay, I can see
About-
that. I
about
thought
20
you would have the, the setup where you can.
You want us to, we could unmute them, but we now have over 70 people on here. So I'm not sure if you want.
No. I thought you had that system where you could put up a question and then you can have a graph of how many people say yes, how many people say no. But it seems that the answer here is unanimous because everybody is saying yes, so 100%. Okay, well, then I guess we need to discuss this topic. Yeah, that is a voting feature, I guess, but I guess that's not, so I think for this question, I don't need to create a poll in Zoom, but for the next one, maybe we can.
Okay, I will try to do that.
Okay, perfect. So we have an answer. So everybody has answered yes on the chat. So I think that's pretty clear. So let me start with a story of one of my patients. And I had organized a course for medical students where they were interviewing patients, and this is what was recorded in that session. And so the patient says to the medical student, and she's educating them because they don't know so much about how hypopara. Functioning without parathyroid is incredible. The first time I had a problem with calcium was a week after my surgery. The ER doc was sitting next to me with the crash cart pouring calcium into my system because he was afraid that my heart would stop. It starts gradually, you get tingles. The student is asking, how does it come on? Is it gradual or sudden? And the patient says it starts gradually. You get tingles and difficulty feeling in your feet. Then you lose strength in your legs and arms, and you can't stand up. You can't move, you can't talk. And at that point, if you do not get calcium in you quickly, then you can't move at all and your heart can stop. So probably this picture is familiar to at least some of you. Dramatic, usually, hopefully not that dramatic, but yet, there are clearly problems that people experience with hypopara. So part of the problem is that managing hypopara is often difficult. And there are several reasons for that. The biology, I would say, is very important, and I'll go through that a little bit. The other thing that's not commonly recognized is their individual differences. Some people can be easily controlled with relatively little calcium and active vitamin D, and others are crashing. And we don't fully understand why there are individual differences. But that is a huge issue because it's a rare disease. And the physician, even an endocrinologist, might have seen one or two cases. Well, if one of those cases is easily controlled, never has any problems, he or she will say, well, it's not a big deal. I saw a patient who had hyperparathyroidism, the opposite. And she already had a failed surgery. And her local endocrinologist said to her, well, go ahead and have more surgery. Even if all parathyroids are removed, it's easy to treat hypoparathyroidism. Well, probably that physician only saw one or two easy cases and didn't realize that having no parathyroids can be an actual issue that is not so easily handled. The other issue is that patients often have other medical problems. And the life experience is one. And so everything that's not functioning in the body or mind or wherever in our system comes together and is experienced as really poor quality of life. So that's important because what tends to happen with practically any chronic disease, everything gets blamed on that condition. Well, you may have other reasons to not feel well, and that should be also kept in mind. And then there are things like, life circumstances, the medical system, as I said, it's a rare disease. Not many physicians are familiar with it. So this kind of lack of understanding of the disease can lead to misunderstanding of patients' symptoms and treatments. So multiple reasons for difficulty in managing hypopara. I do want to talk a little bit about the biology of parathyroid. This is the first talk of the day, and you'll probably see more iteration on the same theme. And many of you have seen this in previous meetings, but for those who are new, maybe it's good to know. So serum calcium is very tightly regulated because it's important for many biologic functions. Nerve conduction, that's why there are so many neurologic symptoms like, tingling and tightness, muscle contraction, blood clotting, and also calcium is what's called the second messenger for several hormones. So some hormones require calcium to be able to exert their effect. So very important, biologically important variable. So it's not really then surprising that patients with hypoparathyroidism have many complaints that are, primarily due to low calcium, and they include paresthesia, which is tingling, kind of numbness, tingling, muscle cramps, twitching, fatigue, decreased exercise tolerance, and if calcium is very low, then seizures. So these are physical symptoms. Then there are cognitive symptoms, something that's called brain fog, and it's not really well defined scientifically, but it's basically suboptimal mental capacity, be it memory, be it how quickly you can complete a task. My patient, who has 4 children, said how when she had low calcium before she was treated with PTH, she had to have Post-its all over her refrigerator to just even remember what she needs to do. And when her calcium normalized, none of that was necessary. And the very important one aspect is that inability to multitask. It's very hard to switch from one task to another. And there are quite a bit of emotional issues in hypopara. Anxiety is very common, depression as well. And anxiety has a kind of physiologic basis because when calcium is low, the person will feel anxious, and then they will start hyperventilating often. Well, when you hyperventilate, you blow out CO2, carbon dioxide. So you make the blood less acidic, more alkaline. And when the blood is more alkaline, then there is less free calcium. The ionized or free calcium is decreased, which further increases the symptoms. So one of the things that we can do is try to deal with anxiety in any possible way as to prevent this vicious cycle of anxiety causing hyperventilation, which then increases the hypocalcemia and so on. So biologically important variables have multiple defenses. For example, sodium in the blood, salt, is very important because it determines the size of the cell. So it's very strongly defended. So if the sodium is high, you want to increase the amount of water in the system. So there is a behavioral mechanism, which is thirst. You all know if you go out and have a Chinese dinner, which you hopefully don't do because that increases, salt increases the amount of calcium lost in the urine. But if you do, you'll notice that there is thirst. You're like thirsty that whole night. So that's the behavioral component. And there is also then production of the hormone called antidiuretic hormone, which decreases the amount of water lost in the urine. So you will then maintain sodium at a normal level. Similarly, for blood sugar, if the blood sugar is low, the person will be hungry and will bring the blood sugar up. If the blood sugar is high, then insulin will be produced and will bring it down. So we have behavioral component and we have a hormonal regulator, if you want. But for blood calcium, which is very important, parathyroid hormone is it. It is supposed to protect us from high calcium and from low calcium. So there is no clearly defined behavioral component to controlling blood calcium. So I would like to poll the audience. Am I supposed to do that?
No,
Okay.
we could do that. You just ask, as soon as you give the question, we'll type it in and send the poll out right away.
Okay, so the question here is, can you sense low blood calcium? Yes or no?
Yes.
All right, it takes a second to type this.
And go.
There you go.
Did it go?
Yeah, it's not letting us do it. So we'll just let everybody answer via the chat.
Raise your hand.
Raise your hand.
Raise your hand for which answer though?
Yeah, raise your hand for yes or to just answer via the chat. So it looks like via the chat, the majority of them are saying yes. But we have sometimes for a couple of people, but I would say it's 98% yes.
So, okay, that's very interesting because I'm just looking at the answers because we don't really think we have a sensor for calcium. So, you know, this is important because if we knew this mechanism was accurate, then it would be very useful in managing. If you're feeling like your calcium is low, you can intervene. But if you're feeling like your calcium is low, you go to the lab and it's normal, then we can't be so sure. And what we really need is some device to measure calcium at home, like we have for glucose. And I think a lot of people are realizing that and working on it. But so I don't know how much of it is through, you know, biologic sensing versus experience. Like when I got tingling or cramping, I measured my calcium and it was low. So, okay, these are the symptoms of low calcium and that's how I know. But it's an important question. And I think something that we continuously need to evaluate and also find way of measuring at home. So, as I said, serum calcium is tightly regulated by PTH. If calcium drops, PTH goes up. And then PTH has several effects on the kidney. It decreases amount of calcium in the urine. It increases the amount of phosphate that's lost in the urine. And it also activates vitamin D from inactive form, 25D, into active form, which is 125 vitamin D, which is actually calcitriol. So that calcitriol then increases calcium absorption through the gut and also the phosphate. And PTH acts directly on the bone to increase what we call bone resorption, that's bone breakdown, which then releases calcium and phosphate into the bloodstream. So the net effect of PTH action is to, oh, now the poll came. Wow, isn't that a delayed response? Okay, can we close it because
Yep.
now we know what to do, right?
Yep.
Okay.
We're learning.
We're learning, perfect. So the net effect is to increase serum calcium and decrease serum phosphate. That's what PTH does. Okay, thank you. Okay. All right, so let's close the poll.
There we go.
Okay.
Close it.
I did.
You did, it's perfect. So when we lack PTH, all of these processes are impaired. So there is no way to activate bone resorption. So bone is staying there, holding on to calcium. It's basically like a rock, not releasing any calcium. Because otherwise, there is a lot of calcium in the bone. That's our major way of regulating calcium, because we have huge amount of calcium stored in the bone. And then whenever you are not ingesting enough, I'm talking about normal parathyroid function, if you don't ingest enough, the bone will release it. Well, that's not possible when you don't have PTH. Then there is no effect on the kidney, so you don't reclaim the calcium in the kidney. As a result, there is increased calcium in the urine, hypercalciuria, which is our common problem in hyperparathyroidism. And because there is no activation of vitamin D, you end up with not absorbing calcium. So all of that then leads to low calcium in the blood. Magnesium is handled similarly to calcium. So magnesium tends to be low and phosphate tends to be high. So that's our situation in hypoparathyroidism. So we treat that by using active vitamin D, which is calcitriol. So we're replacing that missing step. Because we don't have enough calcitriol produced in the body, we have to give a lot more calcium than in normal physiology. So we use a lot of calcium supplements to overcome that diminished absorption through the gut. And for hypercalciuria, for increased calcium in the urine, we can use thiazide diuretics, which decrease the amount of calcium lost in the urine. We can also use phosphate binders for high phosphate, but they have their own problems. They're not really used very much. And in some people, we need magnesium supplements as well. So our interventions then are to provide calcium supplements and active vitamin D. I think practically everybody here has been on that regimen of calcium supplements and calcitriol, sometimes magnesium supplements, and sometimes diuretics. Diuretics are very much a individual choice of physicians. I mean, I tend to use quite a bit of diuretics. There are other people like the Columbia group in New York, they rarely do use diuretics. So it's individual choice, and they have their own problems like low sodium in the blood, low potassium, sometimes low blood pressure, and so on. So not perfect. And there is nothing for decreased bone resorption among these conventional treatments. So the consequences then of PTH deficiency are low serum calcium, magnesium, high serum phosphate. The symptoms, practically all the symptoms from hypopara that I described, we believe are due to low serum calcium, although that's not completely clear. The complications like kidney stones and nephrocalcinosis, that's calcification of the kidney tissue that may lead to kidney disease, they are actually consequences of treatment, because in hypopara, serum calcium is low, and it's serum calcium that determines urine calcium. So when you treat, you bring the serum calcium up, there will be more calcium that goes into the urine. So strictly speaking, the kidney issues are really more caused by treatment than by the disease itself. And the other complication, which is soft tissue calcification, is also more related to treatment, because phosphate is high in hypopara. And then when you bring calcium up, then you increase what's called calcium phosphate product. and then calcifications occur. So can we have another audience poll if we can do it with some speed, which is the question is, symptoms in hypopara are due to low serum calcium, yes or no, versus something else, because that's something that's still debated in the literature. Is it calcium itself, or is there something else that PTH does? So what do you guys think, you who experience the condition itself? Are you typing? I'm going to go on a little bit, but I would like the answer to that poll. So treating then hypopara is a delicate balance where you are trying to control symptoms by giving enough calcium and calcitriol to bring the calcium up. And yet you want to prevent complications, so you don't allow calcium to be really high or even normal. You want it to be on the low side. Because of that, our goals of treatment are low normal or just below normal serum calcium, about 8 to 8.5, and also 24-hour urine calcium less than 300, and calcium phosphate product as low as possible, ideally less than 55. So in effect, we are asking people, patients with hypoparathyroidism, to stay at the level of serum calcium where nobody would feel okay. Generally, most healthy people would probably be above 9. And here we're saying, oh, you should be fine at 8.4. And I don't think people will be fine at 8.4. So it's a huge challenge in terms of what we want people to be comfortable at, which is a little bit against biology. So that's biology that I think is a very important component of poor quality of life in hypopara. Then there are individual differences, severity of disease. Some people are more difficult to control and require a lot more than others. So there is a true individual difference in severity. Then there is a difference in sensitivity to low calcium. Some people feel nothing, and others are very symptomatic, even when calcium is a little bit low. I think one thing that we don't really have a way of measuring that's important is that the absorption through the gut, through the gastrointestinal system is different. Some people will absorb very efficiently, others will not, and that probably determines where they will be. And then compliance is also an issue. You know, the physicians will often say, oh, the patient is non-compliant, that's why they're not well controlled. Well, you know, that may be true, but also if you have to take 30 pills a day, it is really hard to constantly think about it. Plus your calcium is low, your brain's not functioning. So how are you going to remember? So compliance is an issue, but there is a real challenge that makes compliance more difficult. And activity is also important. A lot of people notice that they will have low calcium when they have more activity when they exercise. And there are actually studies in non-hypopara patients where it's shown that heavy physical activity will lower serum calcium slightly, but the PTH will go up and compensate for that. Well, if you don't have hypopara, calcium will drop. And we often say, well, take some calcium before exercising, that might help. So we didn't get the poll, I guess.
Well, the poll did not work.
Yeah, we're having some issues with the poll. It didn't want to come up for some reason. So I apologize. We'll try and capture the results through the chat and let you know.
Okay, so these very last answers are for the question of
Some of them are just questions in general, but there's a lot of answers that were related to your question, yes.
So is the consensus that the symptoms are due to low calcium?
Yes, the consensus is they are due to low calcium.
Yeah, that's what I think also. But there are other people who believe that PTH has some direct effect, particularly on the brain, and it cannot be all attributed to low calcium. Okay, so the third reason that quality of life is impaired and it's not easy is other diseases, like hypothyroidism is common. So, you know, there are a lot of symptoms that overlap, and the studies show that when you compare patients who have hypothyroidism and hypoparathyroidism to those who have only hypothyroidism, the hypothyroid patients have some symptoms, impairment of quality of life. But if they have hypopara in addition, they have further impairment. So all of that works together. Depression is huge. You know, if you're depressed, you don't have energy to do anything, you don't remember your pills, you never feel well, even without hypopara. It's huge. And then anxiety, I already mentioned, particularly common. So anything you can do to learn to decrease anxiety, you know, like the breathing exercises, relaxation exercises, and so on, very, very important, very helpful. And then general low energy and low well-being. You know, there are people who are just like that. Like I saw a hypopara patient who had all kinds of complaints that she attributed to hypopara. And I said, well, when's the last time you felt, you know, strong, you felt well? And she had parathyroid surgery 2 years earlier. And she says, never. Well, you know, you can't expect to feel well if that's just not how your nature is. So that's something to be kept in mind, because everything tends to get blamed on hypopara if you have it. And as I said earlier, there are circumstances in life. It's a rare disease. Most physicians don't know it, so they will base their approach on the 1 or 2 patients that they've seen or something they read. And up till recently, there weren't even many guidelines. So like, where do you even read about it? And it's also important to think about life circumstances. You know, stress is difficult, divorce or illness, COVID, it's difficult for everybody. Well, if you have a weak link in your system, such as having low calcium, it's going to be even more important. And social support is very important. And I think many of you are really fortunate to have families that are very supportive, and that is extremely important, extremely important. So coming back to my patient's story, she's telling this to a medical student, how she had this difficulty. And then she says, it has happened to me 6 times before I was on PTH, since I got the dose right. I get tingles now and then, but nothing like before, suggesting that that could make a difference in quality of life. So what do we know about quality of life? There are multiple studies showing that it's diminished quality of life in hypopara, but does PTH actually improve it is a big question. So the first study was from Colombia. First was reported after 1 year, and then we have 5-year study, basically on SF36, which is non-disease specific instrument for measuring quality of life. Many of you have done it as part of one study or another. The baseline quality of life was low. This is showing standard deviations away from the mean of normals, and with treatment, it improved. That was not a placebo-controlled study. And there is a question because of that. Now, there was an Italian study, also not placebo-controlled, and they also showed that at baseline, the scores were low, and after 6 months of treatment, they improved, and that was kind of maintained at 2 years. we did a quality of life analysis in Replace, which was a double-blind placebo-controlled study with PTH 1 to 84. And the scores improved in several domains in PTH-treated patients, and there was no improvement in placebo. Between group differences were not significant. I was one of the investigators, and my colleagues who were other investigators said, well, it's just not working. And I'm like, no, I can't believe it's not working. My patients are feeling better. I think something is not quite right in the way we're measuring it. So I did more kind of detailed analysis and found several things. First of all, there is a difference between people. Those who start with very low quality of life, they actually had an improvement. So there is, makes sense. If you have something that's already perfect, it's not going to get much better. The other thing we found is that those who took a lot more supplements had greater improvement in quality of life when they took PTH. But the other thing we found is that there were actually geographic differences, because the study was in North America, Western Europe, and Eastern Europe was just Hungary. Hungarian results were different. Then I talked to the Hungarian investigator and I said, how is that possible? Your results are quite different. Are your patients not having an improvement? And he said, no, they love it. They don't want to come off. It's probably misunderstanding of the translation of SF36 questionnaire, even though it was an official translation. So then I analyzed separately the North American and Western Europe quality of life, and I saw clear improvements, actually, particularly in this one domain that's called vitality. And so the vitality domain questions are: feel full of life. The questions are: do you feel full of life, have a lot of energy, feel worn out, or feel tired? And these are the answers all of the time, most of the time, and so on. So it made sense to me that the vitality domain was very much showing the impairment of quality of life. I think many of you probably feel like that. Many people without hypopara do as well, but that I think is kind of a sum total of the experience. And we also looked at the time course and found that the improvement was fairly early, like already at 4 weeks, particularly in vitality. So now we actually have data from the new preparation that's being studied. I think you probably heard about it last night, which is TransCon PTH, which is a 1 to 34 portion of the molecule, but it's bound to a carrier protein, so it has longer duration of effect than 1 to 84, which was previously available as NATPARA. So in this study, and I would say that the study was done a little bit better in terms allowing assessment, better assessment at baseline. What was done in Replace, we increased serum calcium before the beginning of the study, before doing the first SF36 assessment, so that if people on placebo, they don't get too low. So we, in a way, we didn't assess the actual experience. We assessed it when calcium was higher than the target treatment level would be in clinical practice. So there was that, but perhaps there is some benefit to sustain the effect that we have with TransCon PTH. So this was published, and you can see that there was actually an improvement in SF36, which is non-disease specific instrument, and yet we see an improvement. And so you see this is a baseline and then at 4 weeks. They also developed, and several institutions have now developed more disease-specific instrument, which was used in this TransCon PTH study. And on that instrument, which is more disease-specific, there is even a more dramatic improvement. So we have some data that PTH treatment is beneficial to quality of life. We have a lot of patient stories and patient experience confirming that. And we have some data from the studies suggesting an improvement. Could we do another audience poll, which is not working, asking PTH treatment improves quality of life, yes or no?
Okay, Bob is going to try to get that poll up for you. Would you mind if I start asking you a couple questions, Dr. Vokes, while we're waiting for that poll?
Go ahead.
Okay, so we have a question from Megan that says, are hand tremors calcium related?
Could be, but that's not a common symptom. And also hand tremor is common without hypopara. Often it's called benign essential tremor. And what helps to know whether that's what you have is a family history. Usually people tend to have that in the family. Oh yeah, my mother and then my grandfather had that. So that's one characteristic. The second is that it tends to be worse when you're excited. So that's an example where somebody has to give a speech or a toast, and then they're holding the glass and it's shaking. And tends to get better when you calm down. So more likely it is related to something like that rather than hypopara and low calcium itself.
Okay, and then from Elise asking, can low calcium cause gut problems?
Yes, yes. People can have gut problems from low calcium. If you take a lot of calcium, that can cause constipation, particularly if calcium runs high. But the other thing to remember is that people have other issues, particularly those who have autoimmune forms of hypopara. So they could have celiac disease. So it shouldn't always be attributed to hypopara. I think it should be investigated. It's possible, but it should be investigated. So the poll came up. Aha. Wow, that's a better endorsement than any study has ever done. How many respondents to the poll? Can you
22 so far.
How many?
22 so far.
That's probably people who were exposed. Can we, would be really interesting to know how many people have been
on PTH. I was gonna say, because we have a bunch in the chat that are saying, I've never been on PTH, so I don't know. So yes, we'll try to get that poll up for you.
Okay. Okay. So
how many
among the
people have been on
22,
PTH?
so among the 22 who have probably experienced it, they feel that it's helpful, but some actually didn't experience like that.
Okay, so we have another question, Dr. Vokes. What from Kimberly? What causes normal calcium level, blood serum calcium, but high urine calcium?
So as I showed you in those slides talking about the biology, when you have normal PTH levels, blood calcium is filtered into urine. So, the way urine is produced, everything that is in the blood goes into what's called primary urine. And Of that, there would be 180 liters per day. So a lot is reclaimed from that primary urine. That includes water and salt and all different kinds of nutrients come back into the blood. And that's hormonally regulated. So if you have PTH, calcium goes in the urine, but it's reclaimed and comes back in the blood. If you don't have PTH, the calcium goes in the urine and doesn't come back. So even with normal level of serum calcium, urine calcium will be high. In somebody who doesn't, okay, so 51% have been on PTH, and how many responded? You guys are muted. How many people responded to this poll?
Sorry, there was 43 out of 80 responded.
I see. So about 20 people have been on PTH. Okay, so if you don't have PTH, then you don't reclaim calcium from the urine, which is why I was saying that when your serum calcium is super low, then urine calcium won't be that high. But when you then increase serum calcium by taking calcium and calcitriol, it will get into the urine and not be reclaimed and ends up high in the urine. That's why we keep serum calcium at a level that's really not pleasant, at 8.5 or below, where I don't think I would feel well. I don't think anybody would feel well. So we're in a way asking hypopara patients to function at what is not an optimal level of biology in order to decrease the amount of calcium that's lost in the urine and decrease the risk of kidney stones and other kidney problems. I do want to mention, however, that there is something that's called primary hypercalciuria. It tends to be familial. It's seen in 10% of normal population. And that's the tendency to have high urine calcium. So people who have that genetic predisposition already would have high urine calcium without having hypopara. And then when you put hypopara on top of it, they will have very high urine calcium. That's why we see such wide range. People might have normal urine calcium with hypopara, and some will have very high. So there is probably another component to urine calcium other than hypopara.
Okay, Dr. Vokes, we have time for one last question. We have someone who asked, should you take more calcium before exercising?
Yes, I think if you notice that you are having symptoms when you exercise, it's probably a good idea. The study I was mentioning, which was done in patients with normal PTH function, they found that if you take tablets, it doesn't really work. I guess it doesn't get broken down and absorbed. But if you take some liquid form, so you could take a cup of milk, although that's not usually such a good idea because of phosphate, but you can take some form of calcium that's a liquid, that you dissolve in something, and so you can drink that, and that is helpful. I just want to give one more message, which I'm sure will come from other speakers, which is that you really need to control salt intake, because urine calcium and sodium are coupled. So you can achieve a big effect by reducing salt intake.
Thank you very much,
Thank
Dr. Vokes. That was some great information. For those of you that we did not get to your questions today, we will get these answered for you, and we will get them posted at a later date and time. Again, thank you, Dr. Vokes, and we'll see the rest of you in the next session.
Yeah, and we
Okay.
apologize for the technical difficulties.
That's fine.
First session of the day.
You can see even technology is not perfect, let alone biology.
We'll just say it's brain fog.
Okay, bye.
Thanks,
Bye-bye.
bye.